The prevailing logic of modern public policy rests on a straightforward sequence. Stimulate macroeconomic growth, and you invariably improve the population's quality of life. Because concepts like well-being are notoriously difficult to quantify, governments rely heavily on top-line GDP and median income as mathematical proxies for human welfare. But a working paper from the National Bureau of Economic Research by economists David Bell and David Blanchflower tests that assumption against the empirical reality of Scotland. By the turn of the 21st century, Scotland had secured a genuine economic victory, achieving meaningful stabilization and a sustained rise in real household incomes. Yet over that exact same period, the Scottish population exhibited some of the most severe public health and subjective well-being outcomes in the developed world. A soaring economy was presiding over a population in acute physical and psychological distress, directly challenging the assumption that broad economic stimulus cures localized misery. To understand why a rising tide fails to lift all boats, we have to look past the headline numbers and dissect the economic data directly. First, we have to establish the economic baseline for Scotland between 1996 and the early 2000s. This bar chart visualizes Scotland's headline labor statistics. As you can see, the economic activity and employment rates, hovering near 75%, were virtually identical to the rest of the United Kingdom, and those employed workers were earning more. Real median income in Scotland grew by 3.3% per year. Crucially, this growth reached the working class. The second quintile of the income distribution saw the sharpest spike, rising 4.2% annually. Because of this concentrated wage growth at the lower end of the spectrum, overall household poverty levels were in active decline. From the vantage point of a national treasury, the macroeconomic policies were working exactly as intended. Based on standard economic theory, this influx of capital should have triggered a measurable increase in the physical and psychological health of the Scottish public. The objective public health data tells a completely different story. This table breaks down deaths across Great Britain by cause. We start with the demographic baseline. Scotland accounts for 8.7% of the total population, yet they account for nearly 10% of all deaths. When we isolate the specific causes, the excess mortality isn't driven by uncontrollable pathogens. It is driven by localized behavioral crises. Scotland accounts for an astonishing 43% of all alcohol-related deaths. The pattern repeats across other indicators, nearly 26% of deaths from drugs and 15% of all suicides. To put the scale of the crisis in perspective, Scotland's incidence of chronic liver disease was more than double the rate observed in the United States. Economists Angus Deaton and Christina Paxson have extensively studied the relationship between money and mortality. Their work demonstrates that historical patterns of rising incomes or shrinking inequality do not automatically reverse entrenched mortality trends. The Scottish data provides a textbook confirmation. Higher median wages were entirely powerless to halt a behavioral and public health collapse. To find the flaw in the economic narrative, we have to look at the geographic epicenter of this distress, the Strathclyde region, an area defined by the legacy of heavy industrial manufacturing and its subsequent decline. The headline unemployment rate for Scotland looked healthy, but the aggregate data was masking a localized collapse. These two tables compare probability models for standard unemployment against economic inactivity. Inactivity means an individual has completely withdrawn from the labor force and stopped seeking work. Even when holding personal characteristics constant, the probability of being actively unemployed was highest in Strathclyde. But the larger structural failure appears in the inactivity column, a massive surge in individuals permanently exiting the workforce. Local authority data confirms the shift. In Glasgow, the largest city in Strathclyde, disability living allowance claims sit 202% higher than the Scottish average. These figures represent a deeply discouraged workforce. Unable to find employment in a post-industrial landscape, thousands transitioned entirely onto health-related Social Security benefits. The seemingly stable labor statistics were an accounting illusion. The permanently jobless had simply been reclassified as the permanently sick. This physical and economic stagnation maps directly onto the population's psychological state. This diagram visualizes the regression model the researchers used to measure life satisfaction. The model mathematically filters out a control group based on variables like age, marital status, income, and employment. This allows economists to account for the universal miseries of joblessness, or the standard U-shape of human happiness. By controlling for these variables, the model isolates the geographic effect, comparing two identical hypothetical people. The results yield a severe Scotland dummy variable. Even with all economic advantages held equal, living in Scotland, and specifically Strathclyde, has a massive, statistically significant negative effect on life satisfaction. This perfectly aligns with self-reported mental health data, revealing a dense, localized epidemic of depression and anxiety, heavily concentrated in the Strathclyde area. Researchers frequently test the social capital hypothesis to explain this kind of despair, the theory that a lack of community trust and local networking breeds misery. On a national level, Scotland's social capital matches England's, but zooming in on the Scottish Household Survey microdata reveals a localized collapse. In Strathclyde, residents report the lowest perceptions of neighborhood safety, friendliness, and community infrastructure. A minor increase in a weekly paycheck cannot offset the heavy psychological toll of living in an environment suffering from severe physical and social degradation. When we layer these datasets together, the paradox resolves into a stark reality. The data proves a total decoupling of macroeconomic performance from localized welfare. The collapse of heavy industry in regions like Strathclyde left behind deep entrenched deficits in public health and social capital. These deficits function as an institutional trap. Broad national increases in GDP simply flow over them without treating the root rot. This means that relying on indirect, macroeconomic levers to cure structural public health crises is the wrong approach. If the goal of a government is to improve the actual welfare of its citizens, it has to abandon the blunt instrument of top-line economic growth and target the specific vectors of human misery. That requires direct, micro-level interventions, aggressive policies on addiction reduction, dietary improvement, and the physical rebuilding of neighborhood infrastructure. Until policy shifts from chasing GDP to addressing the reality on the ground, populations like those in Strathclyde will remain trapped in the statistics. Wealthier on paper,